It was quite a challenge to recruit patients, but finally we managed to recruit 123 patients. And they were randomized 1-to-1 into the active stimulation arm and into an arm with sham stimulation. And the sham stimulation is also a big advantage of this method because there's a technique that you ramp up the current slightly, and then after a while you ramp it down. And for the sham stimulation, you ramp it down pretty much immediately after you have ramped it up. And for the active stimulation, you leave it up for 20 minutes and then you go down. And the point is that with a few seconds of stimulation, you don't have any physiological effect. But patients do not feel any difference. They don't feel this ramping up and ramping down, and they don't realize that one current stops much earlier. So that's a big advantage. So it's really truly blinded. And that's an exception for these neurostimulation trials, which are very difficult to blind. Now, what we then found was that both groups had very decent improvement of upper arm function. We measured this with a Fugl-Meyer assessment, and this we measured at baseline. And then for the primary endpoint, immediately after the end of the intervention. The intervention lasted for 2 weeks, basically 10 working days, every day repeated and combined with a very rigorous standardized physiotherapy rehabilitation protocol. So after 2 weeks, we did the first assessment of the Fugl-Meyer arm score. And then we also followed the patients up until actually 12 months after the intervention, after the stroke. In total, we had many different time points. First time point was right after the intervention. So basically after 2 weeks. The second time point was after 30 days. The third time point was after 90 days and then after 12 months. And in addition to the Fugl-Meyer assessment, we did many other scores, ARAT, 9-hole peg test, grip strength, stroke impact scale, quality of life assessment by PHQ-9. So a very deep phenotyping. And in both groups, we saw in all scores a very nice recovery curve. And then primary endpoint, and the hypothesis that tDCS creates more recovery, improves recovery, and leads to a greater improvement of the Fugl-Meyer arm score. That was not the case. In both arms, they improved by approximately 9 points on this score in the intention to treat analysis. And also, if we looked at the per protocol analysis, there was no difference. The per protocol analysis, they improved, both groups improved about 10 points on the Fugl-Meyer assessment for the primary endpoint time, so right after the intervention. And when we looked at other scores, or at day 30, or at day 90, or at 12 months, there was no difference whatsoever between treatment arms. So that's the main finding. Besides the fact that the safety and the primary safety endpoint, there was also no observation that would give any concern. So we defined epileptic seizures during the intervention as primary safety endpoint, and we did not see any epileptic seizures, and we also did not see any other side effects that were a problem. So nice method, very well feasible because it's a small battery-driven device. And the patients showed good adherence. That's also important. But at the end, it didn't make a difference.